All right. Welcome, everybody, today to another episode of 7 Minutes with the Expert for Liver Fellow Network. Today, we have Dr. Ann Fernandez. Ann, thank you for joining us today.
Thanks for having me.
Dr. Fernandez is an assistant professor in the Department of Psychiatry at the University of Michigan. She is a licensed clinical psychologist who received her doctoral degree in clinical psychology from the University of Rhode Island. She did her clinical psychology residency in behavioral medicine at Yale, and she did her postdoctoral fellowship at Brown University. I got all that right? Yeah?
Yeah, that's right.
Great. Her area of expertise includes substance abuse, health psychology, and in particular, and part of the reason we have Dr. Fernandez with us today is that she's collaborated with my previous guests, Drs. Jessica Mellinger and Dr. Scott Winder, in the treatment of patients with alcohol-related liver disease over at the University of Michigan. So, Ann, I'm stoked to be able to continue on this journey of enlightenment for myself, for our audience, first with Dr. Mellinger and Dr. Winder, now with you, to really learn more about how we can best care for our patients with alcohol-related liver disease. As you know, Dr. Mellinger and I spoke sort of about how to manage these patients from a hepatology perspective, mainly after their liver transplant. And then Dr. Winder taught me a lot about, the multidisciplinary nature of managing these patients, including sort of how to be sensitive when discussing and diagnosing their disease and then creating a therapeutic alliance. But with you today, I just want to, sort of get a psychologist perspective, if you will, so we can jump right in. The first thing I wanted to start with was this term motivational interviewing. It came up both times with Jessica and with Scott. And
okay.
I take from that it must be important. So maybe you can just tell our audience what motivational interviewing is, if you don't mind.
Yeah, sure. So motivational interviewing it's actually a communication style. So it's not a treatment in and of itself or an intervention. And I use the term intervention as like a point in which you intervene in a behavior, not like a confrontational intervention, the way it's sometimes used. So it is a style of communication that essentially was developed in response to some of the more confrontational language and messaging of traditional addiction treatment. So a lot of times traditionally when people are approached by a doctor or a mental health specialist, even decades ago, there would be a very blaming style and a very advice-oriented style and a denial-busting, intention to it. And essentially, it elicits a lot of defensiveness, and sometimes maybe it would break through to a patient or a person who had an issue with substances, but a lot of times it didn't. So this style of communication was developed by a group, but the main leader of that movement was Bill Miller in New Mexico. And I'd say it has two main parts. It's kind of not rocket science, but it was kind of revolutionary in its development at the time because it was so different from the traditional methods. And there's a spirit of motivational interviewing. So the underpinnings of it are that when you approach communication with someone about whether it's substance behavior or any behavior that the person may be needing or wanting to change, you approach it with compassion, acceptance, partnership, and respect. So you have a intention to collaborate with a person in the discussion of behavior change, or to even acknowledging that a person has a problem, because a lot of people don't acknowledge the problem to begin with. And that's in contrast to like a confrontational style. You use a style of evoking rather than telling a person what to do. So trying to draw out the person's ideas about change or what they think of their own substance use rather than imposing ideas. And you emphasize autonomy. The person ultimately is going to leave the room where you're having a conversation and do what they're going to do.
Yeah.
And you approach with compassion, respect for the person, that they're the ones who know themselves best and are going to be able to make the best choices. So that's kind of the underpinning of it. And then overlaid on that are a series of technical skills or communication strategies. The simplest breakdown of them, given our time together, is an acronym called OARS,
Okay.
which is open-ended questions. So you use open-ended questions. What do you think about your substance use? How do you think your substance use has impacted your life? Instead of, has substance use impacted your life? And they'd be like, no.
Hmm.
The conversation's ending. You use affirmations. So affirming the positive movement that people have made. You reflect back to people what they've said to show it's like an active listening. And then you provide summary statements. So as people tell you their story, you summarize and check that you're understanding it correctly. So those are some essential skills. It gets much more involved than that if you do more advanced training, but it really boils down to a few simple principles that I think if you really embody the spirit of MI, the technical skills kind of come about a little bit naturally.
Sure, sure. That's a great introduction. I want to go back to what you said in the beginning, um, about how it used to be focused on blame, or even just not even so much blame, but confrontation. And I had that thought as I was thinking, preparing for this was, you know, in a traditional sense, in medicine, let's say, patients oftentimes come to our office actually looking for help for a particular thing, right? So maybe it's they have high blood pressure, or they have a hernia that they need surgery for, and they're sort of sitting in front of you, waiting for you to give them your advice. But with
Sure.
alcohol, they didn't most of the time they don't come in
Right.
seeking help with that, right? It's like you solicit that they have a alcohol use disorder maybe, and then you're in that position as the physician or the provider of needing to offer forth advice that was unsolicited, right?
Yeah.
And
Yeah.
so I sense that that's sort of what you're getting at with some of these techniques, but maybe you can elaborate a little bit more on that. Like, how do you, in that moment where you're like, I have to tell this person that they are drinking too much, how do you do that in a sensitive and empathic way when they weren't asking for that advice in the first place?
Yeah, sure. I think that, I mean, to the best of one's ability to try to engage a person, given time constraints of very busy appointments that people have, but to try to get at what the person perceives about their own alcohol use or other drug use would be important. And also to try to figure out before maybe telling them what your opinion is from a medical and health perspective, is try to get a sense of what they perceive.
Mm.
And it might take a little more time. However, if you can even hook them with something that motivates them, it might be their dog, it might be their kids, it might be that they want to pay their mortgage and this would save them money. If there's something that you can get that's a motivator for them that you can hook your advice to, it's just going to give you a little more leverage. So even just trying to collaborate, evoke information, emphasize that choices are up to them. One of the there's some subtle things you can do. There's something called and statements. So often we say, um, I hear that alcohol is something you don't want to give up, but I really think that it would be good for you.
Hmm.
So a very subtle thing you can do is, I hear that alcohol is something you don't want to give up, and I'm concerned about your liver if you continue drinking in this way. So
Fascinating.
little shifts are things that can kind of just lower the temperature of the conversation and open up the person to listening a little more. One other little thing that you could do in a fast-paced environment where you don't have a lot of time, you can ask the person for permission to give them advice.
Yeah.
So it just changes them to an open listening posture as opposed to a defensive posture, to ask, is it okay if I share a few concerns that I have? And then most times they're going to say, yeah, that's fine. I don't know, you're the doctor, they kind of want to hear what you have, but it just kind of changes the tone of the conversation.
Yeah, no, I think I really like that point. It's like, you're asking for their permission to be a part of this conversation as opposed to sort of forcing them into it, right? So,
Exactly.
um,
Yeah.
and then one of the things I came across while I was also reading a little bit more about this was, and you mentioned it, but reflective listening, right? So
Mhm,
I think the way I interpret that is that's sort of a nice starting point of establishing that trust, because when you repeat back to someone kind of what they're already telling you, it really makes them feel heard. Is
mhm.
that part of this too?
Yeah, that's a huge part. It's one of the central tenets of motivational interviewing and why it's believed to work is is essentially this active listening that you do. And showing someone that you hear them helps them essentially move towards change. You know, if you can, I have two toddlers, so I do this not just with my patients, but on a daily basis with
Yeah.
little kids. They're in a totally emotionally dysregulated kind of state. And then you're just like, wow, you're so frustrated that your brother took your toy. Like, I hear you, I see what's going on, and then they can hear what your next instruction is. So it's sort of just this thing that you try to engage with this person, like, I hear you, this is so frustrating, you're drinking because of all this stress in your life and you feel like you can't get out of it, like, I get it. um and I'm still concerned about your drinking. It can set things up for a more successful conversation.
Yeah, I love that you brought up your toddlers. I have a 1.5-year-old, so you can't really engage in motivational
Yeah.
interviewing with her yet. But when you were talking just a few minutes ago, that was exactly what popped in my mind. I was like, this is probably going to work one day with her.
Yeah, I mean, whether you're 3 or you're 45, it's the same fundamental human needs to be heard, to feel like you are in control of your own life. And so it's like the same principles, just at different levels of understanding.
All right. Um, so moving on from a motivational interviewing, because I know we could spend hours on that. Those were some great tidbits and pearls. Um, Another thing I wanted to pick your brain a little bit about was the various modalities of behavioral or psychotherapy that exist for alcohol use disorder. So, personally, sometimes I just look and I feel that there's so many options that exist. And so maybe you could just briefly tell us about the various options and what they are.
Yeah, so I guess there's kind of two dimensions to think about. One of them is level of care. So there's kind of different alcohol treatment options at different levels of care or levels of intensity.
Mhm.
There are also different models to treatment and frameworks to how that treatment is delivered. So in terms of levels of, sort of very briefly, but levels
Yeah.
of care can be anything from a infrequent outpatient interaction between a patient and a provider, to the next step up would be kind of like maybe individual and group treatment in a structured treatment setting. There's something called intensive outpatient programs. These are pretty common in most areas, where it's typically 3 half days a week for a month with
Mhm.
some variation, but that's probably the average, where you go for 3 hours a day to get more intensive treatment. And that would be appropriate when someone has a bit more of a severe problem, where checking in with someone once a week is probably not enough structure. They often are abstinence based, and they track a person's alcohol and drug use through urine drug screens. So
Okay.
there's some accountability and monitoring that goes along with that. And then there's also, for people who have more severe problems where it may be unsafe or medically necessary for them to have a monitored medical detox, which alcohol, of course, can be very dangerous for withdrawals. Then there's detox, and you can have detox by itself. You go for a week and then you're discharged, or you can have detox combined with a residential rehab program where someone could stay for 30 days, 90 days. So those are kind of the different levels of care, and it depends the person's willingness and severity of their alcohol use disorder, probably which of those you want to go to, which a care manager or a social worker sometimes can be helpful in making those designations if
Okay.
that's available to you.
Okay. So that's the like level of intensity and structure. And then within the therapy that you're getting, what types of therapies are proven to work maybe for alcohol use disorder?
Yeah, so it's a little bit of a tricky question. Oh, I should say I didn't mention within levels of care, but the other, of course, well-known and ubiquitous option is like the 12-step and peer support kind of treatment.
Yeah.
Um, so there are many, many effective treatments.
Okay.
The biggest problem is that they are not utilized or not available.
Hmm.
So there's definitely no one treatment that is best. It's going to be individual, and you're not going to know always which treatment is going to work for which person. But there is research on it. There are definitely treatments that can make things worse. Like some of the very confrontational approaches don't work. They make things worse.
Mhm.
Some early aversion therapy where they try to make people they'd like uh, use conditioning to make them feel sick. Like those don't work. They
Yeah.
work for a month and then they stop working. So,
Okay.
but things that work are AA and 12-step. There's evidence that shows that they do work. Um, not for everyone and not all the time. And relapse prevention is a cognitive behavioral therapy technique, a program called relapse prevention. There's empirical evidence for that,
Mhm.
for mindfulness based relapse prevention, for 12-step facilitation, which is essentially you're assigned to a therapist who helps you engage in a 12-step program outside of the therapy relationship and structures and scaffolds that for you. That's been shown to be effective. But when they do head-to-head comparisons of treatments that are active and they have some theory behind them, the findings when they shake out are often that there isn't one that is clearly better than the other.
Okay.
There are a lot of good approaches that work for a lot of people in different circumstances.
That's good to know because I had that question. I mean, I'm not necessarily the one recommending the exact type, but the patients will ask, what should I be getting? What type of treatment
Mhm.
should I be getting? And I didn't really know, but it's good to know that they're mostly equal. And the most important thing, it sounds like, is just getting them to one of these treatments, right?
Yeah, yeah, definitely. I mean, I think that that is a lot of it. Um, I think there is difficulty where a lot of people who sometimes are claiming to do certain treatments sometimes don't actually do them. Like there's not enough people, I think, trained in evidence-based approaches who are delivering them as intended that are out there.
Yeah.
Everybody says they do CBT. I'm not really sure that everyone's really doing CBT, cognitive behavioral therapy. Um, so it's a little hard like to shop around. And I often tell people if you go to a therapist and you really after 3 4 sessions it doesn't feel helpful, don't just keep going.
Hmm.
You can switch. If you go to AA, go a few times, try that, try smart recovery, which is a more like an alternative to AA that uses more cognitive behavioral principles. Try different things. It's like shoes, like you got to try them on and walk around.
Yeah. I'm glad you brought that up because one of my next questions was going to be that, anecdotally, I'm sure this is common, but I've had patients come to me and, in transplant, we get people from all over the state. They might be hours away. We don't know the providers in their area. And
Right.
they'll ask, I'm trying to look for someone, but I don't want to just Google someone and choose a random person. Do you have recommendations? And, I mean, we don't know all the people in every single town that people live in. So it's
Yeah.
a little bit hard to guide them to the right person.
That's impossible for you. Even for me as someone in the field, I would have to call every provider and interview them, and then I still might not know. So it's really more that they should try to get engaged with something. If it's something attached to like a large academic medical center or there's a larger program, um, you know, it's like sometimes you'll randomly have a really good therapist in private practice. I find at least like attached to universities, there's usually a little more standards of a clinic that might be using certain approaches or they're monitoring things a little more, but it's really hard to know. One interesting thing with the telehealth changes to care is that we used to be very geographically bound, but now anyone in your state, you're licensed on a state level. So I could see in Ann Arbor a therapist in Grand Rapids
Hmm.
just as easily. So if you've got people in Chicago who are good and somebody lives 2 hours away, they can still do telehealth if that's what's going on. The licensure applies. So it
Yeah.
may loosen up some things, except if it's Medicaid where you have county
I was going to
rules.
ask you actually about telehealth. So, what would an interview during COVID be without a discussion on telehealth, right? So,
Yeah.
um,
What, while we're on a Zoom call.
yeah, right, exactly. A tele interview about
Yeah,
telehealth.
we gotta
Um,
acknowledge
no,
it.
I mean, there's the detractors and the supporters of telehealth all over the board. But I would love your perspective on the good, the bad. What do you think about that in your field, and specifically as it relates to these patients?
Yeah. I will definitely talk about that. I realized I left one important thing out when I was talking about treatment, which is that for alcohol treatment, combining medication with behavioral approaches is also really important and so overlooked.
Okay.
So when you bring together, you get somebody on well, you can't use some of them for liver, but if you can get somebody who is knowledgeable in that area and knows when it's appropriate to prescribe, like I'm sure Dr. Winder talked about, it is very, very recommended, and evidence supports the combination of behavioral treatment with medications.
Okay.
I just
Yeah.
didn't want to keep that problem going by not joining the two in people's minds.
Yeah. So like I got my patient to therapy, but I didn't put, maybe didn't give them some medication to help is probably not so good, or vice versa. You think
Yeah, or for some people, it's just can be really helpful. Those, like an anti-craving agent, can just really be effective. It depends on the person, but sometimes it can just make a big difference. So it's good to consider them both.
yeah.
So anyway, but telehealth,
Yeah.
importantly. So interestingly, so telehealth from a behavioral treatment perspective, so people who are doing talk therapy as opposed to psychiatrists who are prescribing meds, has not been supported by the insurance companies
Hmm.
until COVID,
Okay.
which means there was very little of it going on and very little research into it. So from an evidence-based perspective, there actually hasn't been a lot of comparisons of like a full, what if you do this treatment by telehealth versus in person? There just hasn't been a lot of work in that with full treatment programs.
Uh-huh.
There has been a lot on like computerized brief interventions or virtual care. And a lot of those comparisons show that the virtual versions are just as effective as the in-person.
Mhm.
So I do think that in some cases it's going to be just as good, but that's often with less severe populations, like those briefer interventions, where for people with really complex problems who need monitoring, who may need urine drug screens, who you may lose a lot from not having an in-person interaction with them. I think we don't know for sure, but someone I work with, her name is Allison Lynn, has done a lot of work in the VA promoting telehealth, even for opioid use disorder medication management. And there's a lot of promising results from that. And she's trying to do some work now with some alcohol use interventions with some like head-to-head kind of comparisons. But it's actually really early days in terms of research on that, just
Yeah.
in part because it hasn't been widespread.
Yeah, I think in my experience in the recent past few months, I can think of at least two people, because the other issue when we're talking about transplant is sometimes time is of the essence. And so you'd love for a patient to be able to shop around, or, like you said, try a few sessions with somebody. If they don't like it, move on. But sometimes we like them to try to engage to a certain degree and show some meaningful change in the months leading up to a transplant.
Right.
So that's a whole an added layer. But I was just going to say, I can think of two patients who actually engaged in a tele IOP, intensive outpatient program,
Yeah.
while in the hospital. Because
Yeah.
the truth is, you sit around for a lot of time in the hospital, and
Yeah.
and so they were 3 hours. It was in the evenings. It was a few times a week. And they derived significant benefit from it,
Yeah.
at least from my brief, talking to them. So
Right.
I think that's
Well,
really
and it's
positive.
Yeah, I think we're doing a tele-IOP so I work also in the outpatient clinic. Our IOP is now a tele-IOP. Um, and I've had patients through the clinic with Jessica, Dr. Mellinger, where we've done our visits. They're in the hospital, inpatient, and I'm at home.
Yeah.
And we're like doing our visit, and I'm like, well, that's great for your transplant status because you can show that you're
Yeah.
continuing to participate despite being in the hospital, which in the past would mean like, oh, you didn't take part in your treatment.
Yeah, for better or for worse, while there are pros and
Yeah,
there are cons, I can't, that's a huge benefit.
yeah,
I really hope the insurance and all the other barriers that were there before COVID don't just sort of come right back up. I think this is a really big benefit to our patient population.
yeah, I agree. Having the option, especially with the geographical limitations of how just how big the catchment area is for big hospitals, it was a big limitation for me when insurance wouldn't cover any behavioral approaches, that people would come into the clinic. Scott and Jessica could continue seeing them and I couldn't. And so this has kind of, I think, leveled the playing field a bit for all the areas of care that they may need.
Yeah. Do you think, I imagine that psychotherapy is predicated a lot on that, the human interaction, that sort of body language, face-to-face
Mhm.
contact. Do you feel like that's lost a bit in telehealth? Is that one of the downsides, or you don't think that that's as big of an issue?
I think that it I think it depends a little bit on the person and maybe the situation, and maybe also comfort with telehealth, and maybe that I just kind of forget what it's like to meet with people in person at this
Maybe that's
point.
true.
Because I know this is just me personal experience. I had my patients that I'd been seeing in person for quite a while, and we switched to virtual, and I didn't like it at first,
Yeah,
and now I'm like, this is fine.
that's true.
So I don't know, like I don't know if I'll go back and then feel like, oh no, I just forgot that it was much better. Um, but I do still see some in person with the liver clinic, and I kind of feel like it's been kind of comparable.
Yeah,
I think with some severe people, um, where you do sometimes want to monitor and maybe get a little more that face-to-face time, they're being a bit evasive, that could be a little easier in person. But I think like a lot of the time it's been just as effective in my perception.
yeah, I think so too. It was a period of ironing out some of the wrinkles on our end, and I just think back to like the daily FaceTime Zooms I have with my parents, and like the internet's
Yeah,
going out, and I can't hear them, and they can't hear
yeah,
me, and it's just
yeah,
a disaster. But no, I think you're right. A little bit of it is just us figuring out how to best integrate it into our workflow and identify the people for whom maybe something in person might be best, and just learning as we move along with this, rather than
yeah.
shunning it outright, because we don't like some parts of it, right? So
Right, yeah, or having it as an option where, if we can hopefully have a menu of options, it's good to be flexible.
great. All right. Well, we talked a little bit about motivational interviewing, and I think the takeaways I have are some of those strategies, like the open-ended questions, and the affirming, people's positive progress. I think Scott Winder mentioned it too, and I think that's
Mhm.
super important. I think it was really helpful to hear your thoughts on the different types of alcohol therapies, and we talked about telemedicine. So it was a great interview. Thank you for joining us.
Yeah, thank you for having me.
Before ending, I like to just ask a question out of left field just to get to know you a little bit better. So maybe take you off guard. But I asked Scott last week what the last book he read was. I can ask you that, or I can ask you when you can travel again freely for vacation, where you want to go.
Oh,
If you need it,
I will talk about the book, I guess, because I don't even know where I go. I have two little kids. Vacations aren't even fun anymore.
that's true.
Like I don't know. I mean, I love my kids, but for vacations,
Being home is
they're
nice.
now they're trips. They're not vacations, they're
Fair.
trips. Um, we'll probably go to Rhode Island to see our family actually, but I am reading two books at once.
Wow.
So I'm reading one called Nine Lives of Pakistan.
Okay.
My husband is originally from Pakistan. He grew up in Dubai,
Okay.
and he wants, I mean, I know some things, but not a lot about the history and the culture. And so I'm about through 7 of the lives, I think,
Oh, wow.
at this
Okay.
point, but it's very good.
So
Uh,
it's nonfiction.
yep, nonfiction.
Okay. Great.
Nonfiction book written by a journalist. And I'm also reading a book my sister sent me called There, There, which is about Native American, like it's fiction, but stories of about like 12 different Native Americans living around the nation, and sort of they come together, and sort of the journey of what it's like to be an urban person with this heritage, and trying to integrate it into your life. And it's been pretty interesting. So
Oh, nice.
yeah.
I'm gonna have to. I love. Scott mentioned the Gulag Archipelago, which was a 3-volume, I think, massive tome on the history of Russia. So you guys are
Oh,
in
wow.
the same boat.
Scott reads more than anyone I've ever met. We had a book club, Jessica, Scott, and I. It was a textbook club.
Oh my
We
gosh.
all read an Asimov novel,
Oh,
and Scott was reading so many books that it took him months, because he was reading like 12 books at a time,
yeah.
and jumping around. So it took him months to get through it. But
Yeah, I think I caught him off guard. He couldn't think of a book for a few seconds, for a few
oh,
minutes.
that's funny. He just had to pick one.
Yeah. All right.
Yeah.
Well, Dr. Fernandez, again, thank you for joining us. Our audience is privileged to be able to listen to you, and I'm certainly privileged to be able to have an opportunity to speak with you. So thank you for your time.
Yeah, thank you. It was a pleasure.